This is Dr. Paul Bryman with Rowan University's New Jersey Institute for Successful Aging. Today I'd like to speak about goals of care and advanced care planning. I've been in the practice of geriatric medicine since 1987. I'm board certified in internal medicine and geriatric medicine, a fellow in the American College of Osteopathic Internists, and a fellow in the American Geriatric Society. I'm certified medical director with the American Medical Directors Association. I'm an assistant professor of medicine at Rowan University in the Department of Geriatrics and Gerontology. I sit on the board of directors of the New Jersey Geriatric Society, and I'm treasurer for the New Jersey Geriatric Society. I'm a member of the American Osteopathic Association, American College of Osteopathic Internists, American Medical Association, American Geriatric Society, and the American Medical Directors Association. I'm the medical director of Heartland Hospice in both Laurel Springs, New Jersey and Northfield, New Jersey, and also team physician in Heartland Hospice, Allentown, and Chadds Ford, Pennsylvania. I'm also the medical director of ProMedica Manor Care in Washington Township, New Jersey. End-of-life care in New Jersey is different than the rest of the United States. Family members and friends of patients at the end of life report that the care that they receive is not always consistent with patients' wishes, and in many circumstances is associated with unwanted aggressive treatment, according to the Governor's Advisory Council on End-of-Life Care that was done several years ago. In fact, New Jersey patients receive more aggressive care than any other state, ranking number one in order of magnitude on resource consumption, according to the Dartmouth Atlas Project. Dartmouth Atlas Project revealed that the residents of New Jersey have the highest number of days in the ICU before dying, the highest use of ventilators before dying, the highest number of specialists on the case before dying, and the most days in the hospital during the index hospitalization in which death occurs. You can review this data at this URL, dartmouthatlas.org. I received no commercial support for the planning and educational objectives and content of this activity. This presentation does not endorse any specific product and does not discuss any off-label use. Materials used in this training are available for public use by the U.S. Department of Veterans Affairs National Council for Ethics in Healthcare, Goals of Care Conversation Training for Physicians, Advanced Practice Nurses, and Physician Assistants. Today, I'd like to discuss how to construct a goals of care conversation in patients with advanced disease and life-limiting illness, and implement best practices when delivering serious news to patients. How to employ the spikes and remap techniques in listening and responding to patients during goals of care conversations, and formulate a treatment plan that matches the patient's goals and values. When care is only focused on disease control or cure, patients do not survive longer, and in fact, they have increased suffering, increased pain, and anxiety. Families are exhausted by the use of frequent hospitalizations that not only don't provide longer life, but actually harm patients. Non-essential, costly acute care through the end of life is especially problematic in New Jersey for no benefit in longevity. Other states have longer life expectancies with less use of aggressive in-hospital care. The National Academy of Medicine report entitled Dying in America, Improving Quality and Honoring Individual Preferences at the End of Life, published in 2015, shows that 5% of spenders account for 60% of the spending on Medicare in the last year of life. Barriers to high quality end-of-life care. Number one, hospice and palliative care are generally absent from the usual curricula in medical and nursing schools. Rowan University School of Osteopathic Medicine is an exception, where we have a 1-week end-of-life seminar that I'm course director for our second-year students. Second, persistence of single profession education silos often exclude specific care of individuals at the end of life, and that's often pushed off to other professionals. And third, most notable among physicians, is the lack of attention to developing clinicians' ability to talk effectively to patients about dying and teaching them to take the time to truly listen to patients' expression of their concerns, values, and goals. I hope to go over clearly, step by step, a structured way that we can learn to do this today. The indications for a goals of care conversation include individuals with metastatic solid tumors, that especially include hypercalcemia or spinal cord compression. Stage 3 or 4, heart failure with 2 or more hospitalizations, or COPD on home oxygen. That's also New York Heart Association class 3 or 4. That is dyspnea with normal activities in stage 3 and dyspnea at rest or with talking in class 4. Chronic kidney disease on dialysis in individuals over 75 are associated with a shorter life expectancy. Advanced dementia, such as Alzheimer's disease, especially FAST-7C or greater, and that would be defined on the functional assessment staging tool as individuals who are incontinent of bowel and bladder, have language limited to less than 6 words a day, and are losing their ability to walk independently. Those individuals, in conjunction with other markers for multimorbidity, including pressure ulcers, aspiration, frequent pneumonia, or urinary tract infections, have been shown to have a life expectancy that's less than a year and are definitely candidates at this point for hospice admission. And I think the simple question you need to ask yourself is, would you be surprised if this patient died in the next year? I think that we underestimate our ability to judge that, but studies have shown that doctors routinely, and unfortunately especially specialists, overestimate their patients' life expectancy. Indication for goals of care conversation would include changes or advancing disease following the hospitalization, ER visit, or consultation for a life-limiting disease, change in status or progression of illness, and common signs for decline of chronic illness, like functional decline, unintended weight loss, cognitive decline, frequent exacerbations of CHF and COPD, and increased complications that go along with disease progression. We bill for advanced care planning conversations with Medicare code 99497 for the first 30 minutes with a minimum of 16 minutes, and 99498 for each additional 30 minutes. Documentation of the start and end time of the conversation is important for Medicare billing. The benefits of goals of care conversation improved quality of life, reduced use of inappropriately aggressive life-sustaining treatment at the end of life, earlier palliative care and hospice referrals, and better bereavement outcomes. Studies have shown no increase in anxiety, depression, or hopelessness associated with goals of care conversation, although families are frequently worried that their loved ones will experience this. Delivering serious news is done using the spikes method. We need to pick the appropriate setting, such as a quiet, comfortable room, turning off our beeper, making sure that we have the right participants there and that you're sitting down. It's very important to note that studies have shown that patients perceive the doctor spent more time with them when the doctor or clinician is sitting down and talking to them than when standing and talking with them. We need to invite the right people into the conversation, determine who should be present, and ask them to clarify their relationship with the patient. Ask which family members should be present and what medical information the patient gives you permission to discuss with the family. You need to give them information, and we frequently talk about firing a warning shot. Instead of just going directly into the conversation, proceed it with, I have something serious to discuss with you. Please avoid using medical jargon. Just say it simple and stop. For example, your cancer has spread to your liver. It's getting worse despite our treatment. And then pause. Wait for the patient to respond and respond with empathy. I know this is not what you expected to hear today. Or, I know this is very difficult news to hear. Always summarize after the conversation by saying, we've talked a lot about things today. Can you please tell me what you understand? Or tell me what you heard me say. I think that it's often underestimated how powerful news elicits powerful emotions, and patients sometimes tune out after hearing the first bit of bad news and sometimes don't hear the rest of what we're saying. So this summary, tell me briefly what your understanding is of what we spoke about today, I think is extremely important and something that's not done frequently enough in medicine. Some helpful resources that I've found very useful that I have marked as bookmarks on my computer under palliative care, for example. Fast Facts from the Palliative Care Network of Wisconsin have uh, uh, things about the treatment of all different kinds of palliative settings, the use of narcotics to treat pain, the use of feeding tubes, and especially have useful tools in determining prognosis in advanced cancer and sections on delivering bad news. The Seattle heart failure model is available for use online in calculating life expectancy in people with advanced heart disease. For prognosis in the elderly, ePrognosis is very useful and ultimately utilizes multimorbidities and comorbidities in assisting in prognosis. For liver disease, the model for end-stage liver disease, or MELD score, is very useful, and I find that I use that all the time in admitting end-stage liver disease patients to hospice. And for individuals with advanced dementia, the Mitchell Index is available also through ePrognosis. So let's break this down and start with talking about the spikes model. After hearing serious news, everyone has an emotional reaction. Clinicians need to attend to this emotion before moving on to anything else. Tools for responding to emotion include naming the emotion and acknowledging it. Naming the emotion helps patients, number one, know they've been heard, and number two, identify what they're feeling. It's best done as a suggestion or humble question. Some people would be angry in hearing what I've told you. For example, your cancer's returned. Despite the treatment, the tumor is spread. Or, I'm wondering if you're feeling sad. We're going to watch a couple of video vignettes and see how experts put this into action. The first is on naming emotion.
Okay. You know, I don't understand. The radiation doctor, when I had the seeds done, he assured me that the whole issue was now in the rearview mirror. Those were his words. They were in the rearview mirror.
And so now it's really sort of disappointing and maybe a little bit of a shock to hear the news. I'm suggesting that we have to actually look further.
Yeah.
Yeah, I can definitely see that. I can definitely see that. Probably makes you wonder about how much you can even trust all this now.
Well, yeah, obviously I can't trust anything the last guy told me. I mean, what happened? Did he screw it up?
Well, what we're going to do is we're going to go ahead. I really see how this is hard. We're going to go ahead and get the scan and find out what that tells us. And then based on that, we'll go from there.
Okay.
So I really like what the doctor did here. He was able to name the emotion, including the patient's lack of trust, and not get defensive, but roll with the pushback. And what he really did that was very effective was help the patient through that and get on to the next steps. A statement that conveys the clinician is trying to understand what the patient is going through is it must be hard. Acknowledging is anything you say that makes it clear that you recognize the patient is having an emotional reaction. You can't truly understand the patient's experience, but you can show that you're trying. Therefore, never say, I understand exactly what you're feeling. In fact, patients sometimes get angry at this. Another video on acknowledging emotion. In this video, the doctor is talking to the mother of a teenager who's been in a critical bicycle accident. It presents an example of the doctor acknowledging the mother's emotion. Pay close attention to the words said, and then we'll discuss what we saw at the end.
Kevin's not going to give up either. Those seizures he's having, it's like he's saying no. He's not going to give up. He's a fighter. That's my boy. I always told him I'd stand by him no matter what.
I admire your strength. I can't even imagine what it must feel like to see your son slipping away like this.
I like what the doctor did here. Number one, by saying how much he admires the mother's strength, and by acknowledging he can't even imagine what she's going through. He doesn't engage in miracle talk. He just emphasizes the mother's pain. So now we summarize and strategize. We make a plan for the next step. Instead of asking the patient to repeat back to you what you said, which can sound a little patronizing, honestly, the language that's used here is more effective. It really puts the onus on the clinician if the patient doesn't understand. So be as concrete as possible. We'll get a CT on Tuesday. I'll see you the next day so we can discuss options. Confirm that the patient and you are on the same page. To make sure I explain things well, would you tell me in your own words what you now understand? Here's an example of a doctor telling a prostate cancer patient that his PSA is increased. You'll see him start out the conversation by assessing understanding before giving the news, and then checking in on that later. In the middle part of the conversation is left out, but pay close attention, and we'll discuss what you saw after we watch it.
I'm not really sure why I'm here.
So has anybody talked to you at all about your PSA test and what that might mean?
No, not really. No.
Okay. Is it okay if we talk about that a little bit?
Yeah, sure.
So one of the reasons I want to see you back is because your PSA test, if you remember, that's the blood test we do to check how your prostate cancer is
Yeah,
doing.
yeah.
Since the last visit, it's gone up a little bit.
You know, I had those radioactive seeds implanted to stop all that.
Right, and I can see how you'd think it should all be gone now. So, Greg, we've just been talking about a whole bunch of stuff, and sometimes I don't explain things really well. So it would be helpful to me if you could tell me in your own words what we've just been talking about, so I can be sure that you understand.
Well, my PSA apparently is up. And you're afraid that my cancer's back. So you want me to do some more tests, bone scan, probably another PSA. Is that about right?
So in this ask, tell, ask scenario, the doctor asks what the patient understands, provides knowledge and information, and at the end of the discussion, checks understanding. I like how the doctor doesn't make it like he's quizzing the patient. He says, sometimes I have trouble explaining things, so tell me how I did and what your understanding is of what I said. We're going to move on to reframing. And in reframing, the first part is we're in a different place, letting the patient know that we've changed scenes and that we're in a different place in their disease. This is designed to teach you the skills required to conduct a goals of care conversation with high-risk patients and their families. What makes these conversations tough, these may be very difficult conversations to have. Care has been focused on extending life, and changing the goal may seem at first to the patient like a failure. Uncertainty is difficult. We don't know what to expect, and we have to make decisions in the face of uncertainty. All people manage uncertainty in different ways, and many people don't do well with it. Emotions come up in every discussion of goals of care, and the clinician needs to recognize it and respond to it. The lack of a framework in which to enter the conversation would be really helpful, like a sign that says, start here, and then, the conversation needs to go through a start, middle, end. We're going to talk about ways to do that. So REMAP is a 5-step map for talking about goals of care. Today we're going to work on reframe and expect emotion. Then we'll talk about mapping out what's important and aligning with the patient's values, and then coming up with a plan of treatment to match the patient's values. Introducing the conversation like firing the warning shot. I have something serious to talk to you about. Would it be okay if I talk to you about what lies ahead with your illness? Instead of launching into it, ask the patient's permission. They may want to ask you to have family there first. They may not want to talk about it today. They may say, could we give me a break from this for a while and let's talk about it tomorrow or next week. Another approach would be, today, I wonder if we can talk about how things are going with your medical problems. One cannot discuss goals of care without first being sure they understand the medical situation. So, what's your understanding of your illness? Here are a couple of statements that could be helpful in discussing goals of care. If the patient doesn't have a clear understanding, we're in a different place than we were 6 months ago. People may say, the other doctors told me everything was fine and I'm doing better. That conversation may be something they heard 6 months ago. So we're in a different place than we were 6 months ago. If the patient does have a clear understanding of where they are in their illness, it may seem like a good time to talk about where to go from here. Most patients have an emotional response on hearing the reframe. This is normal. The emotional response may sound like a factual question. Isn't there something else you can do? Or are you sure you've looked into everything? Respond with empathetic statements, even if the patient's asking a question. Name and acknowledge the emotion. I can see that you're really concerned. I get a sense that this is not what you're expecting to hear today. Ask permission before moving on. Only after the emotion has been attended to. Is it okay for us to talk about what this means? And this is where I'd like to introduce the use of I wish statements. It's another tool that we use to let patients know that we acknowledge their emotion. And we'll look at a video example of this. Here's a doctor responding to the patient's question of, isn't there more we can do? And reframing that with an I wish statement.
Is there anything more you can do?
Can you tell me a bit more about what you're thinking?
I'm an optimist. I want to clutch at every straw there is. If we haven't done everything, I got fight in me. Let's do the next thing.
You know, I want to acknowledge the fact that you've always been a fighter, and that's a quality in you I've really admired. You know, I know it's really hard for you to hear that there may not be another chemo or treatment for your cancer. I wish there were, but I'm just afraid that there's nothing out there that's not going to do you more harm than good.
If this is going to get me in the end, and there are no other options, let's get comfortable.
What specifically did you like that the doctor did in that video? Rather than responding immediately to the question, the doctor probes for more emotions that are driving the question. Can you tell me more about what you're thinking? And then he uses an I wish statement to align with the patient when she expresses the desire to pursue more treatments that wouldn't be helpful. Next, we're going to talk about eliciting the patient's values and priorities for their care and mapping out what's important. Given where you are in your illness, it seems like a good time to talk about where we go from here. We're in a different place than we were X months ago. and then expect emotion. How would you respond to, are you sure we've tried everything? There's always been other treatments that worked. Or especially, are you saying that we're giving up? You need to ask permission to continue after each statement. And these are like signposts to the next conversation. Is it okay if we talk about where we go from here? You must know the patient's goals and values before creating a plan. The only way to do that is by asking. If asked correctly, the question makes sense and isn't scary. Here are some examples of words you can use to ask patients their goals and values in a non-obtrusive, non-threatening way. Given this situation, what's most important to you? Knowing that time may be limited, what things are most important? As you think about the future, what do you want to avoid? What do you want to make sure does not happen to you? As you look to the future, what seems more important, the quality of your life or how long you live? I think we can't make assumptions about that. I think it's a particularly important question to ask patients and then use that to probatively ask them why. Do they have a specific goal in mind? For example, I have a patient just this week whose goal it was to live until their granddaughter's wedding. And at that point, she's now ready to stop a lot of the medications that I've been asking her to stop that may be having side effects at the end of her life. Make sure that you're asking what is most important to the patient, not the surrogate. So if you're talking to a surrogate, you have to really make it about the other person, whether that's their parent or their child, their spouse. If your dad were sitting here, what would he say is most important? What would your mom be worried about in this situation? I frequently find that if I ask probative questions about that, your mom's currently at home. If she goes in the hospital and has this, there's a likelihood you won't be able to take care of her at home and she may need a nursing home. At that point, the family may say, Mom would never have wanted to be in a nursing home. If your son was sitting here and could hear what we were saying, what would you want to avoid? So I often find some helpful techniques in doing this. If your mom was in her right mind 40 years ago and wrote down on a piece of paper something for you to read today to help you make this decision, and you reached in your pocket right now, what would that piece of paper say? Families frequently will start to cry at that point, and it really helps them bring out what their loved one would have wanted, not what their goal personally is. Be curious. Ask multiple exploratory questions. Don't stop after getting one or two answers. Really be interested and curious about what's most important to the patient. And the conversation is more about the patient's goals. Be careful not to impose your agenda and your values, and not try not to talk the patient out of their goals, but tell them their goals, are I'm sorry, don't tell them their goals are unrealistic. Resist the urge to ask the patient to rank their goals at some point in the discussion. Understanding the trade-offs, including the risks, benefits of treatment, including futility, should be discussed, but it's important to inform the patient about these decisions and ask them what's most important to them. Don't have an agenda, and don't be judgmental. And here's a video about a doctor asking a patient what's most important. Pay close attention to the words the doctor uses here.
I guess I expected the scans to be even worse. So, we do now?
It's a good question. And actually, I'm going to answer that question, and we'll talk about what the plan can be. But first, to help with that, it would be really useful for me to know if it turned out that time was limited, what's most important to you right now?
I honestly haven't even faced that question for myself.
Well, tell me what things are most important as far as what you care about, or what would you like to be doing?
Like to get away from all this and not be doing testing and being in hospitals and being around doctors. Nothing personal. I wish I could just go away. Go on a trip someplace and just enjoy life for a while.
What would that look like? What would enjoying your life really look like?
Sitting on a beach, reading a big fat novel slowly, listening to music, just having fun and not having to think about this.
Yeah, those are great things. And sounds like those are things that you haven't been able to do or think about in a long time.
And are those things that I can do?
I think that there's a lot there that we can work on.
What did you like that the doctor did here? I like that he asked what things are most important to you, and then help the patient explore those. Next, we're going to talk about aligning the patient's values and plan treatments that match the patient's values. Once you've mapped out what the patient or surrogate's goals and values are for the treatment, it's important to first align those with the goals before making a recommendation. Repeating what the patient just told you, I believe, is most important. Make sure that they understand that you heard them. Make sure you've got it right and the patient feels understood. So if the patient says, this has all been hard and I'm really tired, I'm really worried that the pain might get worse. I know I don't want to end up on a breathing machine like the last time I was in the hospital. I never want to go through that again. And I haven't been able to really be with my husband and kids. I'd like to get back to that, maybe go on a vacation and have some fun together. And the clinician says, as I listen, it sounds like what's most important to you is that you stay out of pain, spend more time with your family. It also sounds like you would not be willing to go through things that cause you a lot of pain and suffering, like being on a breathing machine again. Does that sound right? Sort of the ask, tell, ask again that we looked at before. And then plan treatments that match values. Ask permission to make a recommendation. Stress here that you've heard them and I'm going to now make recommendations that match your goals or values, not reiterate a whole list of available options, but I'm going to make those recommendations that would help you specifically match your goals and values. So the recommendations would focus on what can be achieved, or focus on what might be possible, but also discuss what we do not want to do because it will not meet the stated goals that the patient just gave you. After making recommendations, ask the patient and family whether that feels right. Based on what you've told me, I would recommend this, this, and this. Does that sound right? And check to make sure that they understand the treatments you're recommending and provide additional knowledge and information if needed. Would it be all right if I make a recommendation? Given what you've told me is most important. There's a lot we can do to help. We'll focus on keeping you out of pain. We also can get some services in your home and help you stay there and spend more quality time with your family. We look forward, we will work toward that vacation and have a better idea of how possible that is after we see how you feel on the new medication. In addition to all these things I've mentioned we will do, I also recommend that we don't consider further scans, blood tests, or pursue aggressive life-sustaining treatments like putting you on a ventilator if your heart stops, doing CPR, because at this point it won't help you achieve your goals. What do you think about that plan? Would it be all right if I offered a recommendation? Given what you've told me is most important, it sounds like you'd want to pursue any treatment that would give you a chance of living longer, even if that means your life might be supported by machines. Does that sound right? Is there any situation where you can imagine you would not want your life to be supported by machines? I think that that last sentence is a vital part of this conversation with people who want, quote, everything, unquote, done. First of all, it's important to understand that everything is never always on the menu. And so asking them, you'd want to go back to the ICU, you'd want to be on the ventilator again, you'd want to have CPR. Can you think of any circumstances where you would not want that done again? And I think that opens the door to some real important planning that and in a conversation that you can have with the patient whose goals include all life-sustaining measures. We'll give you some examples of this and we'll talk more about that in detail. So here's a video on recommending a plan that aligns with goals. Here's a doctor making a recommendation. Pay close attention to the words used.
So would it be helpful if I made a recommendation regarding what we should do, given what you've told me?
Yes,
Okay.
please.
Let me make sure I got it right. What's most important for you is feeling a little bit better and staying at home and not having to see doctors and nurses so much.
Yeah.
Right. Okay. Given that, I think what we ought to do is we ought to stop chemotherapy, because that way you don't have to keep coming in so much. And we ought to focus on making sure that all our treatments try to make you feel better and give you some time to stay at home and read your books and be with your significant other.
Isn't that just letting the cancer run free?
You know, I wish we had a way to not let the cancer do what the cancer's doing. I think we've tried that. It hasn't really stopped it. I guess what I want to focus on is what's important to you.
And the way to do that is quit chemo.
If it doesn't help and it interferes with helping you achieve your goals, it seems to me that it's not gonna get us where we want to go. And I know it's hard to give it up because it's been such a big part of your life for so long.
You'll be there with me, right?
Yep. We'll do this together. And I think that we really can make you feel more comfortable.
Then that's what I think we should do.
So what I really like what this doctor did is I like how he used the pauses and allowed the patient to absorb what he's saying and made sure that she felt understood. He doesn't dismiss the idea of hope, but he explores what's most important to the patient. And he stays positive and uses language of hope. I like his use of I wish phrases, and I especially like where he says, we'll do this together and I'll be here for you. Next, we're going to talk about discussing life-sustaining treatments. These include artificial nutrition and hydration, which is often referred to as feeding tubes or IV fluid, mechanical ventilation, cardiopulmonary resuscitation, and others such as dialysis, transfusions, and transfer to the hospital or ICU. As a subacute nursing home medical director, we have something in the nursing home besides a DNR and a DNI, do not resuscitate and do not intubate order, and that's a DNH or do not hospitalize order. We have that in subacute rehabilitation, nursing homes, and home hospice settings. And it's very important to have that do not hospitalize conversation with families. It's not a permanent do not hospitalize ever. There's a case-by-case basis. There's circumstances for the provision of certain types of palliative care that we may need to use the hospital. But there are some people who would rather stay home and never go back to the hospital no matter what, or for whom the hospital has told them coming back here is not going to benefit you. It's going to continue to make you worse and harm you by making you weaker or causing you more pain. We'll talk about that in a little bit when we discuss the New Jersey Practitioner's Order for Life-Sustaining Treatment. We're going to go through a little bit more knowledge now that we've gotten those skills under our belt. First, we're going to talk about outcomes for CPR. For most people, the information they have on cardiopulmonary resuscitation comes from television. Depictions of CPR on television create an overly optimistic impression about CPR's effectiveness. In a study that was done looking at outcomes of CPR portrayed on shows like ER, Chicago Help, Rescue 911, across the 60 episodes that were studied, 77% of the patients on the TV shows survived the immediate cardiac arrest, and most implied long-term survival. Real-life outcomes are not as positive. Among adults who receive CPR in the hospital, studies have shown 56% died during resuscitation efforts, and 27% died before hospital discharge. Only 17% survived to hospital discharge. Among patients over the age of 65 who received CPR in the hospital, 49% died during resuscitation. Those are the black figures. 34% died before hospital discharge. Those are the gray figures. 17% survived to hospital discharge, the red and green figures, but only 10% were alive a year after discharge, and those are the green figures. I'd like to look a little bit more at the risks of CPR in the elderly. This figure illustrates the risk of CPR in the elderly in that people experience cognitive disability after CPR in those over the age of 65. Among those who survived CPR and had good cognitive performance before their arrest, most, 86%, had good cognitive performance after CPR. Some 14% had moderate cognitive impairment. There's also a risk of not being able to return home or being able to care for yourself after surviving CPR. In a recent large study, 83% died during CPR prior to discharge, 9% were discharged to an inpatient nursing facility, and 7% were discharged home, and 1% were discharged to hospice. The percent of patients surviving with good neurologic function after CPR for those 80 to 84 years old were only 7.5%, and over 85, only 4.5% survived with good neurologic function. What are some of the unintended consequences of language? If we ask a patient, would you like us to restart your heart? Restart implies the procedure is easy and effective, like turning on a light switch. It's not. Most patients did not survive CPR to return home. Restarting the heart is usually not possible. Would you like us to do everything possible if your father's heart stops beating and he stops breathing? Well, everything possible is really not what we can do. How can anyone say no to this? It sounds like the alternative is doing nothing. And we really never have the option of doing everything. So this is an example of the clinician not being clear or the patient not having enough knowledge to make an informed decision. And we would never say, I think it's time to withdraw care. Withdraw implies stopping helping, and we may stop certain treatments. We may not recommend certain treatments to meet your goals and values, but we are always there for you. We never withdraw care. We're always there to help and care for you and your family. Now, as you read this, this is an example of making CPR sound like a senseless act of brutality. It conveys that the provider has an agenda to talk to the patient and really talk them out of a treatment approach. It really sounds judgmental and coercive. We wouldn't talk to patients about shoving tubes and breaking ribs and those type of things, where instead we would give them knowledge and information about how CPR may not help them meet their goals, or how unlikely it would be for them to survive to returning home to a normal life. But a scenario like this about pressing it on your chest, breaking your ribs, shoving tubes is really an attempt to frighten people more than to have a conversation with them. Our role is to ensure that patients receive treatment consistent with their values and goals by helping them define what's important to them, understand the outcomes, and is the treatment likely to help them meet their goals and make informed decisions. It's a much more patient-centered approach than having a discussion whose point is to get the DNR order. So we've talked about reframing, expecting emotion, mapping out what's important, aligning with the patient's values, and planning treatment to match their values. After mapping out what's important to them, if the goals point to a clear plan for life-sustaining treatment, ask permission to make a recommendation. Ask to recommend treatments that support the patient's goals, what might be possible, and important to also talk about what not to do because it wouldn't support the patient's goals. Let's do some examples. The clinician would say, based on what you've told me, if you get a lot sicker, it wouldn't make sense to put you on a ventilator, or if your heart stops, to do CPR. I'm worried that if that happens, you wouldn't get off the machines, and if you did, you'd be a lot more dependent. That's what you said you want to avoid. And the patient would say, that's right, I didn't want to go through all that. After mapping and aligning, the patient's goals do not point to a clear plan, recommendations regarding life-sustaining treatment. The patient wants cognitive information about life-sustaining outcomes, and there appears to be inconsistencies between the patient's goals and life-sustaining decisions. If the patient goals don't point to a clear plan for life-sustaining treatment, is it okay if we talk about some medical treatments you might or may not want if you become sicker? For example, the patient may have multiple goals, some of which are incompatible. There are some things that you need to do to begin to discuss life-sustaining treatment with patients and explore their preferences. Can you tell me what you know about, for example, dialysis? Would it be okay if I share some information with you, for example, about feeding tubes? What information would be helpful? Helping patients explore the trade-offs associated with treatment decisions will help them make decisions that will clarify the relative priority of their goals. If the patient wants information about outcomes, you mentioned what would you want? I'm sorry, you mentioned you would want CPR if it would bring you back, quote unquote. Would you like to know about the chances of survival after CPR, or would you like, or what your life might be like afterwards? Is there any other information that might be helpful? Do you prefer general information, or do you want to know numbers or averages? If you don't assess what the patient wants to know, whether or not they want general information or specific odds, you may be providing information that would be overwhelming to them. Try to avoid being an information avalanche. Assess the level of information they want and provide what they want and need at that moment. If the patient's decision about life-sustaining treatment seems inconsistent with their stated goals, they may not recognize this, or it may be that the relative priority of their goals is different than you originally thought. Explore this by using supportive language and be sure you understand whether the circumstances the patient would want to receive, under the circumstances under which the patient would want to receive something different. So you could say, I worry that a feeding tube won't help you reach your goals. An example of this may be a family who's worried about a patient with cancer who stops eating or drinking, who's going on to hospice, and you're going to be providing comfort care to that patient. A feeding tube won't help them even if their appetite is decreased in achieving comfort. It's normal for patients who have end-stage cancer to slowly eat and drink less and less. Explaining the normality of that to a family and helping them achieve the goal of providing comfort on hospice to the patient would then avoid having that feeding tube conversation as being the sole focus of the conversation. It would help you shift the goals toward what they want, which is go home and to be comfortable. Tell me more about what you're hoping for with CPR. Is there a situation where you could imagine you would or would not want to be on a ventilator? After life-sustaining treatments have been made and documented, it may be appropriate to review them at a later date. Use caution not to inadvertently introduce doubt when reviewing decisions. Are you sure you don't want CPR can cast doubt on the decision. It's like asking, is that your final answer during a game show? The question's meant to make contestants second-guess themselves. When talking to surrogates, start by reviewing what's known about the patient's goals and preferences and ask them if they have any new information to help support the patient's wishes. When the patient's goals of care have changed, or a change in the patient's condition means that the odds of treatment will meet the patient's goals have changed, discuss the patient's goals by using the remap technique and rediscussing these decisions. Let's look at some drills. The clinician may say, I can see how important your family is to you, and I really respect that. Can you think of a situation when you wouldn't want CPR? Patient may say, I want to give CPR a chance, but if you try it and end up with brain damage, I don't want to try it again. The clinician may want to explore the limits of that a little bit more. Tell me what you mean by brain damage. Okay, if you develop the patient may say, if I get CPR and afterwards I'm not able to take care of myself or make my own decisions, then I wouldn't want CPR again if my heart stops. I don't want to be a burden on my family. Clinician may say, okay, what if you develop those problems before CPR? Patient may say, then I wouldn't want it. So instead of just taking their answers as their final answer, asking some probative or follow-up questions, some what-if questions, is very important in this scenario. At some point, You would want to attempt CPR if your heart stops and you stop breathing. But if you are permanently unable to take care of yourself and make your own decisions, you would not want CPR. Do I have that right? Patient may say, yes, that's right. It's now time. So if the goals point to a clear life-sustaining treatment plan, ask permission to then make recommendations. If the goals don't point to a clear life-sustaining treatment plan, ask permission to talk about treatments with the patient that they may or may not want to have, assess their understanding of the treatment, and assess the information the patient may want and provide it. Explore decisions that do not appear to match their goals. At this point, in the state of New Jersey, we have a physician's order, a practitioner's order for life-sustaining treatment. I think that after a goals of care conversation, it's a good time to pull out the green piece of paper and ask permission to immortalize these discussions as a physician's or practitioner's order. The first part of the New Jersey Pulse form, the first part of the New Jersey practitioner's orders for life-sustaining treatment is the goals of care. I usually use this to write a simple statement, summarize the patient's goals: to remain home, to remain pain-free or comfortable, or to live as long as possible. Under the medical interventions section, you can choose full treatment, limited treatment, or symptom treatment only. Under artificially administered fluid and nutrition, you can choose no artificial nutrition, hydration, or defined trial or long-term artificial nutrition. Under CPR and airway management, you can choose attempt to resuscitate or allow natural death. You can choose intubate, do not intubate, or a defined period of intubation. It gives you the opportunity to say that I don't want my surrogate to modify this, or I do want my surrogate to be able to modify this, and put the name of the surrogate decision maker here. Patient or surrogate decision maker signs it. It could be the patient, their healthcare representative or legal guardian, their spouse or civil partner, or the parent of a minor or another surrogate decision maker. It's important that the clinician, APN, or physician's assistant sign over here, and that this license number is put over here. Vital Talks is available to make communication skills in serious illness learnable for clinicians, faculty, and institutions. They have excellent training programs. They also have an app you can download that has a lot of information, especially communication in the ICU, having conversations for patients on ventilators, and it's available on their website. Much of it is free. Additional resources include Goals of Care New Jersey, that has their 4-step plan, an individualized end-of-life plan, and that can be accessed at the URL goalsofcare.org. I'd like to end with a book that I found really important for things that matter most. We had to do a lot of video conferencing for people with COVID where families weren't allowed to visit, and that's where I first became familiar with this book. It allows people to get on with the work of dying and to complete relationships. It involves 4 steps: families, loved ones, significant persons, asking 4 things: please forgive me, I forgive you, thank you, and I love you. These are steps to saying goodbye and completing relationships in people who are at the end of their life. And I find this to be invaluable in helping me have conversations with people.